Are you looking for relevant healthcare information? Log on to Medicircle and watch experienced medical professionals talking on common healthcare topics. Stay informed, stay healthy, stay tuned to Medicircle.
We at Medicircle are constantly working on bringing to our audience all the trending health related topics. It is our primary objective to bring to your attention news and views you need to be aware of to lead a healthy, disease free life. To help us in this regard, we'd be joined by eminent and expert top doctors from across the country. Today in Doctors Speak, we are going to talk about the problem of PCOS and ways to help you deal with it. Hello, this is Aprajita Mehra, and you are watching Medicircle. Today on our PCOS awareness series, we have Dr. Sandeep Reddy Ganta with us. Dr. Sandeep Reddy Ganta is an endocrinologist having experience of 6 years. He has completed his MBBS in 2010 from NTR University, Vijayawada, and his MD from Osmania Medical College in 2015 and DM Endocrinology from Sri Venkateshwara Institute of Medical Science, which he completed in 2020. He is a member of Endocrine Society of India and he is currently practicing in Kamineni Hospital, Hyderabad. It is our privilege to welcome him on board to Medicircle with this interview. Welcome to Medicircle, Dr. Sandeep. How are you today?
Fine. Thank you. Thank you for a very good introduction of mine.
Oh, the pleasure is all ours. So let us quickly move to the first question of the interview. How is PCOS diagnosed, sir?
So PCOS is the most common reproductive and metabolic disorders in a woman's of age from 18 to 45 years of age. So PCOS is diagnosed based on the symptoms and laboratory evaluation and imaging wise. So if you go to symptoms, it will be irregular periods. Irregular periods will be menstrual cycle lasting more than 45 days, or one cycle last more than 3 months, or if the cycle lasts less than 21 days also, we can consider the irregular cycles, or less than 9 cycles per year considered as the regular cycle. So other thing is hyperandrogenism features will be there, like severe acne, which is not respond to any conventional treatment, nodulocystic acne, we will call it as, and hyperandrogen. Other features is excessive overgrowth over the body, including face or lips and over the body. There is the unwanted excessive hair growth. So this is the common features. Some patient will develop severe hyperandrogenetic features like change of voice and muscular male body type of muscular pattern will be there, and breast atrophy is there. So basing on the symptoms of irregular cycles and clinical hyperandrogenism, biochemically we will diagnose by doing a androgens level. Androgen level we will calculate on the day 2, day 5 cycle of menstrual cycle. So if it is more than 0.6, we can label it as hyperandrogenism. That is another diagnostic criteria. Some people use the LH-FSH ratio. We endocrinologists won't use that. And we rule out the other causes of secondary PCOS, like thyroid problems or some cortisol excess problems and late onset CH, which is an enzyme deficiency. After ruling out all the causes, we label it as the idiopathic PCOS. And in addition to this, we'll do ultrasound. Ultrasound, which will know the polycystic morphology in the ultrasound. So in that polycystic ovarian morphology, we'll get 2 to 9 mm follicles, which are ranging from around 9 to 10 follicles. Or transvaginally, we do follicular count. It is more than 25. So basing on this symptom, we will diagnose PCOS. PCOS is a long-term metabolic risk factors like type 2 diabetes, obesity, NAFLD. During evaluation for PCOS, we look at the fasting blood sugar and OGTT and HbA1c. We will evaluate for diabetes, and we will evaluate for obesity and also dyslipidemia. That is, we'll check fasting lipid profile. Another is you check for ultrasound for any NAFLD and LFT for non-alcoholic fatty liver disease. These include the evaluation of PCOS.
All right, that was very well explained there, sir. So we have realized that PCOS has a lot of, pregnancy-related myths and confusion, abounding it. So my next question is similar to that, and my question is that can IVF or ISCI help a woman with PCOS get pregnant?
One of the long-term problem with PCOS is infertility, in especially reproductive age group. They are unable to conceive because of there is a ovulatory dysfunction will be there, where ovum is won't released in time. So there are a lot of fertility options will be there. First fertility option will be lifestyle modification. Lifestyle modification include low calorie diet and exercise to produce a weight loss. If they have a weight loss of 7 or 10% of body weight, they will have a decreased symptoms will be there. So after weight loss, they would have conceived naturally without need for any medications. Some people requires the ovulatory induction drugs. One thing is clomiphene, another thing is letrozole. This clomiphene drug will stimulate the release of ovum, thereby it increases the chance of pregnancy. But problem with the clomiphene in especially PCOD is multiple pregnancy. There is a multiple follicles at a time can be released. So it causes a very rare complication of hyperstimulation ovarian syndrome (OHHS). This which is a very serious complication, which can occur with the clomiphene or especially gonadotropins. We have three types of medication. One is clomiphene, one is letrozole, and another is gonadotropins. These are medicines for ovulation inductions. So if the patient is not conceived with these medications, we mostly this infertility specialist will advise for IVF with ICSI, intracytoplasmic sperm injection. Clomiphene and gonadotropins will cause a very serious complication, which is called ovarian hyperstimulation syndrome. And there is a chance of multiple pregnancy with the gonadotropins and clomiphene. So another thing is IVF or ICSI. When the patient is not conceived on ovulation induction mechanism, they go for IVF or ICSI. So the chance of pregnancy will be high with the IVF or ICSI. But there are a lot of complications will arise from IVF or ICSI during ovulation induction. Patient may develop this OHHS, ovarian hyperstimulation syndrome, and chance of multiple pregnancy also there with the IVF. Other option is laparoscopic ovarian drilling, so that they remove some part of the ovary, so that the androgens level will be come down. Especially in PCOS, the androgens are very high, so that they prevent the ovulation. So if you remove some part of ovary, that androgens level will come down, and there is a high chance of fertility will be there, which is usually previous treatment before IVF and ICSI. This is the treatment maybe there for IVF and ICSI. Some other medications are there, especially metformin tablet, which is used for diabetes, which can also be used in PCOS. If the patient having a fasting blood sugar more than 100, that also increase the chance of fertility rates. So, and also in PCOS, pregnancy outcomes will be different compared to normal pregnancy without PCOS. There are high chance of gestational diabetes, which is more complicated and more adverse perinatal outcomes, and high chance of preeclampsia, that is increased blood pressure during pregnancy, and high chance of polyhydramnios or oligohydramnios, and there are low birth weights and high birth weights will be there, especially during the pregnancy. PCOS will decrease the chance of fertility. Even if the patient conceives, there are high chance of pregnancy related complications.
All right, so there seems to be a lot of problems coming out of this. Another question that we normally receive from our audience is that, is it true, doctor, that pregnancy cures PCOS? How much of this is How much truth is there in this statement?
Pregnancy is never cures the PCOS. PCOS is a cause will be different. Pregnancy, once a patient become pregnant, the symptoms won't come down. So pregnancy never cures. The pathogenic mechanism of PCOS mainly due to overweight, weight gain, which can lead to insulin resistance.
Right.
There is an increase in the insulin release,
Mm-hmm.
and there is a hormonal imbalance will be there, where you can have a excess estrogen and very low progesterone. So, and excess androgens, which are normally seen in the males, but in females, that androgens will be very low. But in PCOS, there is increased androgens level. Once a patient become pregnant, there is a quiescent period may be there after 6 months or 1 year. If the patient have a weight gain, again they will get the symptoms of PCOS. PCOS will never cure. There is a no cure for PCOS, so we can control the only symptoms.
And that, you just brought us to our, in fact, the last question was the same that you've just mentioned, that we wanted to know if there is a cure for PCOS, because with the kind of problems that it ensues for the women. Um, so no problems, then how do we manage it, if at all?
No, actually there is a no cure for PCOS. Some of the doctors could have claimed that we can cure the PCOS. No, any body or any organization don't defend a cure for PCOS. So ultimately, we can control the symptoms. First thing is a lifestyle modification. One lifestyle modification include we have to take a low calorie diet and exercise, and also low glycemic index diet. Any diet which can cause us a weight loss. The weight loss should be around 7 to 10% of initial body weight. Means if the patient has a 70 kgs, they can lose around 7 kgs to decrease the symptoms and regularize the ovulation or ovulatory problems or bleeding problems, anything they can regularize. With weight loss, androgens also will come down, and the main pathogenesis will be insulin resistance. That will also come down with weight loss. Other treatment will be this OC pills and progesterone withdrawal bleeding will be there. OC pills are mainly act by mainly suppress the elevated FSH and LH, which are normally seen in the PCOS. They regulate the hormonal imbalance which is caused by PCOS. These OC pills mainly decrease the androgen levels, that is testosterone or other androgens, they will decrease, and they also regularize the bleeding periods. So problem with PCOS is there is a little amount of weight gain will be there, and long term it decreases the long term risk of endometrial carcinoma, which is the long term complication of PCOD. The use of OC pill will decrease the long term risk of endometrial carcinoma. But there is a side effects will be there after 35 years of OC pills, especially increased risk of cardiovascular problems with the OC pills and bleed. This venous thromboembolisms will be there. So we should use a caution after 35 or 40 years of after 40 years of age, especially with OC pills. Other pills will be progesterone withdrawal bleeding, which is usually used for diagnosis, and also some patient who are not fit for OC pills, like the patient having a migraine, a patient having a severe diabetes, a patient and history of CVA. Already patient has established a cardiovascular disease, we cannot use OC
Mm-hmm.
pills. In that case, we will use this progesterone only pills. Other treatment will be we have a hyperandrogen features will be there, that can be controlled by mainly weight loss. First mechanism, lifestyle modification. Other thing will be anti-androgens, that is a spironolactone, which is the most commonly used drug for PCOS to decrease the androgens levels. And other treatment will be already I told, that is a metformin tablet. If the patient has a fasting blood glucose more than 100 or postprandial more than 140, we can use a metformin to prevent the onset of diabetes or to regulate the ovulation. And for if the patient has hirsutism, we will advise to go for laser therapy to already present hair. After that, to prevent the further development of the hair, we can use OC pills and anti-androgens like spironolactone. And other thing will be in PCOS, we will have a constant contact healthcare worker so that he can evaluate for long-term complications like type 2 diabetes, obesity, dyslipidemia, fatty liver, and endometrial carcinoma. These are the all long-term complications. Every 1 year, you have to evaluate for all these complications. For diabetes, we will do fasting and postprandial, and fatty liver will do LFT and ultrasound, and obesity will measure the weight, and for dyslipidemia will measure the fasting lipid profile. Ultimately, PCOS is a lifestyle disorder where when the patient is eating a junk food or refined carbohydrate leading to the weight gain, the problem of PCOS will be start. So it is mainly genetic and environmental thing. Genes will be present in the PCOS people because of environmental factors like intake of excess refined carbohydrates, junk food, and lack of physical exercise. These will precipitate the PCOS symptoms. So that way it is genetic. We don't have a permanent cure, but you can control the symptoms with mainly lifestyle modification. If you continue to have a lifestyle modification, you don't get the symptoms at all. Probably you can defend, might be it is a cure, they defend as a cure, but if again they have a weight gain, they will again develop the symptoms. Even after menopause also, patient might used to get diabetes, cardiovascular disease because of this PCOS. Even after periods stopped also, patient used to get a long-term complication if you have a history of PCOS. So that's it.
All right. So very well, very elaborated answer there. And I'm sure almost all our doubts and, confusions regarding PCOS have now been, allied by you. PCOS itself is not easy to live with. If at all you can, all you can do is just manage. So thank you so much, doctor. It was great meeting you today. And thank you for your time and insights that you shared with Medicircle. It was really a pleasure having you today. Thank you so much.
Okay, thank you. Thank you.